This wasn't working.
Hi, everyone. I think my audio is working.
It is.
Great. So welcome to the panel on discussion on transitions of care. We'll give folks just a minute to get into the session. And then the plan is that we will hear from several speakers briefly, and then we'll have a chance for a group discussion. I'll ask everyone to stay muted unless they're talking, and down at the bottom of your Zoom screen, you may or may not know that under the reactions tab, you can raise your hand. So since I'm anticipating we'll be a pretty large group, when we get to the discussion portion, you can raise your hand and then I can help call on you. And this part of the conference is going to be more informal, so the goal is to have a discussion. And I think with that, I will go ahead and introduce our panelists. So we have Doug Carr here from Umpqua Health, and Stefan, I'm going to butcher the name.
Okay.
How do you say it? Mechanic.
Yep.
From Iris Healthcare. Great, welcome. And they will be talking about advanced care planning. And then we have Cheryl Ramirez, who is going to be talking about transitions of care in the BH system, especially those related to residential placements from the state hospital. And then we'll also have Athena Goldberg talking from All Care Health, talking about coordinating care through a climate crisis like the wildfires down in Southern Oregon. So without further ado, I'm going to turn it over to Doug and Stefan.
All right, Doug, do you want to introduce yourself first, and then I can take it away?
Yes, I'm Doug Carr. I'm Chief Medical Officer at Umpqua Health. I've been with the organization. I'm entering my 5th year. I'm an internist by training, and a lot of my background has been as a practicing internist in both the clinic and hospital setting before I entered into administrative work. Stephen?
All right. And I'm Stephen Mechanic. I'm the Chief Medical Officer for Iris. I was raised by my grandparents. I was in a different field of medicine. My grandmother was diagnosed with metastatic breast cancer, my grandfather with dementia at the same time. Really sort of tore the family apart. I felt like even as a physician, did not know how to help them through the journey of serious illness. And that was about 20 years ago. I've been doing palliative care since. So before it was a recognized specialty. So at Iris, we hold the most difficult discussions in healthcare. We're an advanced care planning solutions company. We work with people with serious illness. Our partners are anybody who's in value-based care, so health plans like Umpqua and Centene, ACOs like Aledade, delivery systems like Scripps, and physician groups like Privia or Genesis. Just very quickly here, we're still spending a couple $100 billion on unnecessary care that I bucket as unnecessary, unwanted, or non-beneficial. There's about 12 million people that have serious illness and don't have access to advanced care planning. We now know, I sort of died on this hill, we now know that physicians won't be the ones to have these discussions. There's just great data for it. It's not going to happen. Even when you incentivize them, it doesn't happen. And so that's why we created Iris. So we have a suite of services around advanced care planning. I'll focus on Empower and Premier, as that's what we do with Umpqua. Just at a high level, we actually predict who needs advanced care planning. So sort of the gateway into the algorithm is serious illness. So, CHF, late stage malignancy, ESRD, cirrhosis, COPD, et cetera. And then we will bring members and their families together for this process. This differs greatly. So I'm a practicing doc. I've been seeing patients all morning. I see them in their homes. Where this is different is we do this evenings and weekends. We get everybody together to hear the same information, talk about what's important for their brother, get to ask questions. It's a very unique and powerful experience for people. We will then create their advanced directives. It's not just the state forms like the directive to physician, the medical power of attorney, and the post. It's our forms as well, which go much deeper than the state forms. And then we widely distribute them. So they go to the member, the family, the health plan, the PCP, the specialist, the hospital system they live in, and they live online. And it's not just the documents, it's actually the conversations. Everything we do is recorded, whether it's video or phone. So if 6 months later we disagree on what our brother said, there it is in his words. If you're the treating clinician and you're skeptical, it's memorialized. And then it's a longitudinal service. We follow people over time. We know that as their disease evolves, so will their preferences. We'll actually help manage them through their hospital stays towards those goals that they set up. And we'll do referrals to things like palliative care and hospice where that's available. The other thing that we do with UMCA is we have sort of like the TurboTax of advanced care planning. This is for healthier people. And so this is a platform where ACP is a very intimidating process. All the forms are very legal. It's filled with legal language. This allows you to get advanced directives done really simply in a non-intimidating way, change them anytime you want, and share them from the platform. In terms of working with UMCA, we've been fortunate enough to be their partners since the beginning of 2021. We serve their Medicaid folks as well as their duals for the Premier service, and then they've decided to offer everybody in Douglas County the ability to use Empower. So anybody there is able to do advanced directives and change them and share them as often as they want without cost, which is great because usually estate attorneys do this and the cost is around $1,500 or more. Dr. Carr, I'll ask you, just in terms of your decision making to work with Iris, maybe you can share a little bit there.
Thank you. Yes, here are some of the numbers. It's clear that just simply from a health plan dollars and cents point of view, it makes a lot of sense for health plans to offer this. Unnecessary care in the last 6 months, a significant return on investment. In Medicare, it's 8-to-1, and Medicaid is maybe a little bit less, but still is important. It reduces the angst among clinicians and patients and families. And there's also a wealth of literature supporting the benefits in various populations, including Medicaid. And Black and Hispanic Americans are less likely than white Americans to have advanced healthcare directives. It's important that these racial differences may represent important disparities in quality care at the end of the life. At UMCO Health, since the start of the year, over 507 members have completed the process. We first focused on what we thought was our backlog of priority patients, those hospitalized 2 or more times in the last year. And then we expanded it to the high-risk patients, the usual suspects as Dr. Buchanan has identified. But now that we've done that, we're very comfortable with our relationship with Iris, and we're providing automated feeds from our billing system to allow for Iris's algorithm to improve efficiency, so there's less hands-on issues. And it still allows our care coordinators and providers to refer patients. Satisfaction from members and providers is very high. A net promoter score of close to 90 is pretty darn good. And every month when we get together, they provide us with audio clips from patients and at the end of their process. And boy, it's just fabulous. So we believe that it meets multiple criteria, the premier product for HRS flex funding because we can link it directly to patients. And then the self-service program, the Empower, we plan to use HRS CBI funding for that. And we think that it's a great value to Douglas County and as a member of our community. So I think that's, oh, here's, I'm not sure that we can you?
This is awesome. Yep. This is something we've had on our mind for a long time and didn't know where to go or how to do it. So this is just totally awesome.
Well, fantastic.
It takes a big relief off of both of us. That's one but it should be.
Yeah. So, I mean, I'll tell you, I provide these clips to our board of directors, and they're sold on the program. And so we'd welcome any questions about it from anyone in the audience.
Okay, well, let's save questions for after all the panelists have had a chance to go, and then we can certainly open up for questions. So next we'll go to Cheryl Ramirez.
Hi, this is Cheryl Ramirez. Can you hear me first of all?
Mm-hmm.
Yay. My name is Cheryl Ramirez. I'm the Executive Director of the Association of Oregon Community Mental Health Programs. I'm going to use my 5 minutes just to do a short introduction of our mission and core responsibilities of community mental health programs, and then tick through a list of transitions of care challenges with a few examples, and then lastly offer potential solutions, some of which are in the works. I have no visuals, so it's just me talking because there's so many things to say. So I'll start by saying that community mental health programs, our association was formed in response to the 1963 Community Mental Health Act, and a group of community mental health providers formed an association to support deinstitutionalization and the community mental health system in Oregon. This began in 1966, and through several iterations, we became a trade association that represents all CMHPs across the state and has for the last 3 decades. You may know that one of our key responsibilities and a component of our core mission is to support deinstitutionalization by transitioning people when they're ready out of the state hospital and out of jail and prison. And of course, we're there to help prevent institutionalization and incarceration in the first place. So some of the examples of our role in transitions of care and also preventing the higher levels of care are pre-commitment services, commitment supports and services, post-commitment jail diversion, reentry transitions. We are choice providers. We provide aid and assist community restoration and community consultations. We work with PSRB clients. We provide crisis services and manage the crisis system at the local level, respite, supported housing, intensive treatment like ACT. So those are some of the things we do to transition people to lower levels of care and help to prevent them from higher levels of care in the first place. So just to tick through some of the major challenges in transitions of care. One is the lag in getting OHP benefits reinstated from members transitioning out of jail or the state hospital. And if we're not able to arrange non-emergent medical transport, or the client absconds, or they had medication and they're missing doses because they're not getting the medication that they need right away, or housing, I mean, you name it. CMHPs end up using either non-Medicaid funding to help them out in the transition. The choice funding is limited, but they use that a lot for housing stability. And of course, it takes a lot of time to problem solve, and sometimes the members go without and bad things happen. Another transition of care challenge that I imagine most of you are very well aware of is that there is no access for people under civil commitment at the state hospital right now. I think in August 1st, I think there were 13 civil commitment patients in the state of Oregon. That's an unprecedented low. And as you also probably know, the hospital is full of aid and assist patients. So when something goes awry at the state hospital, it impacts the whole system of care continuum. So it impacts acute care hospitals and all of the work that we do as community mental health programs to try to keep people safe in the communities. Another component of the problem of access at the state hospital for people with under civil commitment is that since there are so many aid and assist clients, we found it very difficult to keep many in the community due to their housing status. I think the data shows that about 70% are homeless. So it's very difficult for people to recover in the community when they're homeless. Okay, another issue is in discharging out of acute care hospitals. We found that those who are discharging for physical health issues receive automatic coordination by hospitals with primary care. Medical records are usually integrated. We do our best in the community mental health program world to keep tabs on clients through pre-manage. I think is it called collective medical now? Yeah. And it's very laborious and it's a manual process. We'd love for this to be more automatic, systematic for the behavioral health part of the system too for our clients, so we know what's going on. A huge issue is absence of housing, residential. It's very, very difficult to transition people out of higher levels of care or from incarceration if we don't have enough beds. And this runs the gamut from the very highest level of restriction, SRTF, secure residential treatment facilities, to down to single apartment units, and we just don't have enough of any of that type of housing. And part of this is because if there's not a place for people to go, like at the state hospital, then we need more facilities at the community, and it's difficult just to come up with an SRTF just like that. It takes some development. It's very costly care, and exacerbating the housing and residential problem, we have a huge workforce crisis right now, just as the state hospital is experiencing. So those go hand in hand, the housing crisis and the workforce crisis. We've got extreme shortages all the way from peers to psychiatrists, but in the CMHP world, it's especially QMHPs, the master's level clinicians that are have been on a mass exodus from the public behavioral health system. So of course that affects residential programs. That's where we're losing a lot of people too. It's hard work. We're also losing people out of the crisis services part of our system, especially, and intensive services such as ACT. So it's very difficult to keep people in the community when we don't have the people to serve them or the housing. Next, we're noticing higher acuity. There may be many reasons for that. Don't have time to get into that. But we have people who have both mental health, substance use disorder issues, but also physical health issues. So what we find is in one setting, maybe there's expertise to serve the person for their behavioral health issues, but not physical health, or vice versa, not both. So that's been a real challenge. And then the individual has to be eligible, let's say for APD, aging and disability, but then they're not because they're not old enough. So there are lots of challenges like that. We also have people who will never be able to aid and assist in their own defense. And so there's kind of a gap in how to help people who are never able and who just cycle back and forth from the jail to the state hospital back to the community. I know I'm running out of time, so I won't go into a lot of detail. And then lastly, and this is maybe underpinning all of those problems, is the underfunding of the behavioral health system. We just simply do not get enough funding to cover all of the services that we need to provide. They're not always client-facing services. They're 24/7 capacity services. They're just not always billable, and that is a big problem. So let me just end with a few potential solutions, so I'm not just completely in a negative space here. So, and some of these solutions are they're in process of being done, so that's a great thing. So first of all, and these are in no particular order, investment into integrated EHRs and health information exchange for behavioral health. I know that that is in the works, and we could just use more staffing and also for training too. Housing and residential development, there is a special purpose appropriation that was passed by the legislature in the 2021 session. We're very grateful to provide funding for development of SRTFs all the way down to supported housing. We could also use subsidized housing for our workforce, especially in communities where it's very, very expensive to live. They can't afford to live in the places they're trying to work. So that's a big issue. We would love to have an influx of emergency cash for the public behavioral health system right now, to keep people there, to keep our workforce there through bonuses, incentives. There is a bill that passed in the 21 session to help us with this, to recruit behavioral health workforce, but it's just not coming fast enough. We need administrative rule and burden changes, because that's another reason why people leave the public behavioral health system, and variances right now to allow our workforce to do things that maybe QMHPs do for now, because we're just in crisis right now. I think the incentive metrics that are through another service, another special purpose appropriation will be helpful, and the alignment of roles between CMHPs and CCOs in particular will be helpful, and that's all coming down the pipe. As I said, we're underfunded. We need rate increases, bonuses, scholarships, payments of loans, other incentives to recruit and retain our workforce, payment for education in exchange for staying in rural areas for a certain period of time. All of that would be helpful. Looking forward to robust crisis services through a mobile crisis bill that passed in 2021, as well as the 988 crisis system planning. We need more mobile crisis teams. They're staffed by behavioral health clinicians and peers, and so that we can prevent incarceration and institutionalization in the first place. Looking forward to the 1115 waiver renewal updates that would include Medicaid coverage for 30 days in jail or state hospital, so that we can aid in those transitions to communities, and gives us some time to get them lined up with their benefits. I'm also very interested in lieu of services, funding for social services and supports. I think that's really interesting. And then lastly, we could use enhanced funding for choice to stabilize people in the community, coordinate care, provide flexible services, and a lot of that funding goes toward housing too. So I'll stop there.
Thank you so much. I know that you all could talk for much longer than you've been given today. All right, so now we'll turn it over to Athena Goldberg with All Care Health, who's going to talk about providing service through a climate emergency like the wildfires in southern Oregon.
Hi, everyone. My name is Athena Goldberg, as Erin already introduced me, and I'm here in Southern Oregon, and I'm distracted by all that Cheryl Ramirez had to share, because I'm the VP of Behavioral Health for the CCO here locally. And really, I'd like to bring you back only a year, it feels like much longer ago, when we here in Southern Oregon were started with a spark and ended in quite an experience for all of us. And I know that experience, unfortunately, has been shared throughout Oregon during this last year in the midst of COVID, nonetheless. So it was sort of an all hands on deck, and really an opportunity to see, from my vantage point, really what the CCO was originally designed to do, which is to really stand up and become that hub and link resources and oversee that sort of broad unmet need that may be in our community daily, but certainly in light of a huge tragedy that we experienced here in the Talent and Southern Oregon region, really sort of highlighted all the ways in which we do that daily on a really intense scale. So it was September 8th when the fire really took spark here in Southern Oregon. And what that meant for all of the staff in my CCO, All Care Health, was that it was an all hands on deck, which meant our IT team in coordination with our care coordinator, care coordination staff, and really pharmacy staff, everyone came up with a plan of action while we were really trying to assess what the damage may be and the impact might be. So we had real-time tracking about which services were still open. We were really unclear whether or not, like, for example, the behavioral health unit here in Asante was going to be shut down due to concerns around fire and where we're going to have to transport our members, and really kind of owning that responsibility. So we knew that we had 1,300 members that lived in this geographic area that we knew would be already impacted, and then had to assess for the likelihood of their continuing to be impacted as the fire moved, and trying to assess the containment. So our IT team stayed up and created this map, a heating map, which we probably kind of come up with a better term rather than a heat map. But it worked, and really it was amazing. We could plot where our members were, where their primary care providers were, what their special needs were, if they had DME, what their prescription status might be if we needed to. Every department just amazed me. As I say it, I feel like I'm taking ownership for things that other departments, just the foresight and proactive nature of it all was just an amazing sight to behold. And we had huddles daily to see what pieces were in play, what pieces we might have missed. For example, our health equity team really made sure that they were at all meetings to make sure that there were people who could sign and that were multilingual. We had a sense of what languages might be most needed in what resource areas, and we had to have staffing at all of the sites. So we had sites for people who may be displaced by fire at the Jackson County Fairgrounds. There were some other informal sites that were not overseen by the county, who oversaw the fair site, the site at the fair. So some people, we found most of our Hispanic population, for example, gathered at one specific just a parking lot. And so we were able to, because of our relationships within that community, recognize that that might be a gap, and we could, send resources out there, dispatching phones, food, shelter, stabilization. And really, I myself ended up, just because of, as Cheryl Ramirez shared earlier, that lack of resources from a behavioral health perspective. My concern from that lens was that we really did not have enough crisis workers, given that we have a dearth of those provider groups. So, I took rotation and was on call to be available for any unmet crisis needs, given that I'm a licensed provider. Our medical staff did the same. Just any way that we could think of being available for our members, we made sure we looked at the response rate from people that we'd heard from, people that we hadn't heard from, and sort of tick them off so we could place where they were, which, as I verbalize it, sounds a little creepy, but really our intent was to make sure that there wasn't someone out there who really needed an assist with breathing, with medication, as I said, just basic quality of life concerns that we have already paid for through our plan, but they may have lost due to fire. So we had to come up with very creative strategies. Flex funding was mentioned earlier. So, people lost glasses, dentures, things that, we really had to be creative and work very tightly with our provider community, who were extraordinarily responsive to really try to meet those needs. I will also give a shout out. We, from a behavioral health lens, had to really make sure that people who, for example, were taking medical assisted treatment, so methadone clinics, that we were able to make sure that those methadone, dispensaries that were closed, we had other means, and everybody really worked hard, but we needed a hub, which left me immensely in awe of all the work that All Care did within our community and within our organization, via communication through departments, to really ensure that we had good connectivity with our members and our partners. We did have partners who had to, as I shared, close and relocate. One of our addictions providers lost part of a building. And so coming up with strategies to help them rebuild and look at solutions moving forward. But I think it's a great example of the necessity for that, again, that flexible spending and the possibility of in lieu of services, et cetera. I think what stands out to me is, as Cheryl shared with the behavioral health system, is often those services, as I described, that volume where all of these employees internally are working diligently. Some of them, like myself, was also displaced by the fire, and spent my time in the back of the car trying to organize treatment facility placements and residential relocations. No PHI was shared, but it was really in all hands. And those are expenses that ultimately our health system is not designed currently to pay for. Really, that's an admin burden when it comes down to it that isn't calculatable. It's we're capped out at a certain amount for admin dollars. And my concern is, as we move forward, we are going to see more crises like this, unfortunately, and our ability to respond is going to have to be robust and proactive. So looking for cooling stations, solutions for air quality and access for in-home, purifiers, et cetera. So I think it's really going to challenge us to think creatively and proactively about how we're going to respond and fund those sort of gaps that we haven't really looked at as healthcare, but ultimately really define the well-being psychologically of our community and the physical health of our community. So I'll end there and pass it back to Erin and open to any questions.
Sorry, I was muted. So let's open it up. Does anyone have a question? Feel free to use the raise your hand function or just unmute yourself and ask the question. I'm surprised that there aren't any questions.
Maybe it's Monday. It's Monday.
Right, it is Monday
I'm very
morning.
shy. And I'm trying not to ask Cheryl Ramirez a billion questions. Just the interconnectedness, I think, as we talk about transitions, I just see the connectivity between all levels of care and types of care, which is really the work that all of the coordinated care organizations and provider groups really are focused on often.
Right. Cheryl, do you want to say anything about that?
Yeah, I mean, like I said, I think that there are lots of problems. Obviously, I had a long list in transitions of care, and some of them are regulatory, some of them are about the financing of the behavioral health system. And the fact, I didn't really mention this, I guess I made the assumption that everybody is acutely aware that COVID has just exacerbated all of these problems. So with the workforce crisis, we were having problems keeping especially QMHPs in the public behavioral health system before COVID, but it just got worse. People are just really burned out. And when they have the option to go somewhere else where they don't have to work in person, they have easier work, they're not trying to help people who may not really want their help, and may be very hard to serve, and make more money on top of it, then that's a very big incentive to leave. So I would say our biggest worry right now is the workforce, just trying to work that out. And then housing is a very super close second. And I think, as Athena said a couple times, we need all hands on deck here. And I agree, we're going to have more wildfires and other things that happen amidst or in between with the pandemic and all the other problems that we're having. So I think we need to really work on being prepared and try to nurture our workforce so they'll stay.
I would add something, as Cheryl said, kind of alluded to, is that I would be curious for all of you. I know that as I shared my experience here in Southern Oregon at All Care, really we relied on the relationships that we have developed at a local level to really kind of plug those systems. So as Cheryl's kind of talking about the behavioral health system, I can think about our choice provider here locally and the importance of being able to call them directly and having that knowledge of who to speak to navigate together and, thread resources. So I'm sure there's other people on this call who can certainly, speak to that in their own world about what that means and how that works.
Anyone in the audience want to jump in? It must really be a Monday morning.
It was interesting.
Stephen?
You had mentioned telehealth, COVID changing how we deliver, and Dr. Buchanan's approach toward providing this service used Zoom before Zoom became commonplace. Now people are very adoptive of this because they've had their own providers talk to them over direct communication, video conferencing, and it's kind of the way that we're going to be doing things in the future. And just one other service, we're looking at other services to make more efficient. We're looking at improving people's food choices, et cetera, using registered dietitians by telehealth and other kinds of services, all enabled by an external vendor who provides a quality service and can then allow us to do other things that we need to do and we know how to do. And so I think that as CCOs, we're going to have to think about what are the things that we should have service providers provide for us so that we can concentrate on the things that are important that we can only do.
Stephen, would you like to say something?
Well, I will say that just to Dr. Carr's point, my patient panel right now, they very much like having Zoom visits. This is in my practice. I would say about 65 or 70% of them prefer telehealth visits. And that's because a lot of these people don't feel good and they don't want to have to get ready and then drive and then find parking and then come into the office and be in the waiting room when they're nauseated and all this kind of stuff. And it's very understandable. And I just hope that legislation changes so that we can serve them in perpetuity through the model that best fits for them. I love the people that want to come in person, love when that happens, but recognize that it's tough. And I think it leads to, there are these caregiver syndromes, right? So when you're a caregiver, we know that the cost of your healthcare goes up, the number of diagnoses that you have goes up, you're at higher risk for death than non-caregivers. And a lot of it is just, leading a very medical life and having to get that patient to all these different appointments and lab tests and so forth. So I think the more that we can bring the care to the member or the patient, rather than historically that member or patient coming to us, the better that we're all going to be off. But we have significant legislative barriers to that, right? So you can't, for instance, we can do it now during a pandemic, but you can't prescribe opioids, for instance, through a telehealth visit nationwide. That's not related to Oregon. That's federal legislation. It's on hold because of the pandemic, but it's things like that that will have to change if we want to continue to improve the experience for these people and decrease total cost of care.
From Margot, which says, what roles are the CCOs playing to ensure that members have access to the internet and technology to allow them to engage in telehealth, particularly in rural communities? Would any of our speakers like to talk about that, or anyone else?
Well, we've found that smartphones are essential for our membership, and we give them out, and we sign people up for Obama phones and assist them in doing it so that we can have a permanent solution. But between phones and minutes, it's very important, because we also find that texting is really the way that people prefer to receive information. They don't want to answer phone calls. They're suspicious of phone calls, and so that's what we're doing in Douglas County. How about you, Athena?
We're doing something similar. I mean, all of those things that you just listed. I think the issues that came up were really for us, and I think that are an opportunity to really think, from a community lens, is really rural settings where the internet is really non-existent, or the bandwidth is very low. So I think that's been part of a larger community conversation, and luckily those spots are few and far between. But you have to be very creative and responsive to really the individual member needs, which are always not the same, as we all know all too well.
If I could just add something, through CARES funding and ARPA funding, we were able to buy our clients iPads and desktop computers for like senior centers and that kind of thing, for connectivity too. So just wanted to add that.
And I can throw in there, hi, my name is Jackie, I'm from Gobi. We have a HRSA grant that we're in our year 4 now, that has been able to provide a telehealth platform called Mend. And then we've had additional funding for equipment to provide iPads, phones, data packages, and hotspots, and any other needs regarding connectivity, or like I said, data packages to meet with their providers.
That's great.
I was actually very surprised, if I may add, Cheryl reminded me, as we were trying to respond and foresee any unmet needs in the face of COVID and fire displacement, we looked at, it was amazing how fast the iPads and all the technology went out the door in response. But when we reached out to providers, a lot of them had proactively really purchased a lot. And so we were able to distribute some funds to reimburse those funds that they had spent, really looking at it as an access opportunity for our members. So for example, with COVID, a lot of our providers were really creative, as I'm sure others were as well. So that maybe it was telehealth, but the member may want to come into the community, the building, but really due to COVID needed to stay away. So they would be in the other room. So it would be telehealth, but they were still in the same vicinity. So our providers were really creative in solutions. And I was really pleased to hear that. So I'm sure other people have had a similar experiences in their area.
Yes. And we are pretty much just out of time right now. Does anyone have any parting thought before we say goodbye? And I'd like to thank Cheryl, Douglas, Stefan, and Athena for joining us and sharing a bit about what you do. Parting thoughts?
Thank you, Erin.
All right, great. Well, so
Thank you.
yes.
Oh, I just said it was our pleasure. Thank you.
All right, so now logistically, there is a bit of a break, and then we will get started in a little bit less than 10 minutes again back in the main session. We're going to hear from Senator Wyden, and then there will be a legislative panel. So stick around and head back to the other website. All right, thank you all so much.